Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Aaron Bull. He's VP of Strategic Programs at DrFirst, and Dr. Brian Yeaman. He is a primary care physician and healthcare technologist. Welcome, guys.
Hey, thanks so much for having me today.
Thanks for having us.
Yeah, excited for this discussion. I think, this is a topic that probably doesn't get enough attention, talking about advanced care planning for patients, although it impacts so many. So I'm glad we're talking about it. But before we go there, Aaron, maybe you kick us off. Tell us about yourself and DrFirst.
Sure, absolutely. So I'm actually an engineer by education, but I've been doing healthcare for over 20 years in a variety of settings. And with DrFirst, I'm really helping them expand in some strategic programs, but we play in the medication management space, secure communication and collaboration, and really just focusing on that patient journey in the healthcare ecosystem.
Awesome. Brian, how about yourself?
Been a family physician for 20 years. I was chief medical informatics officer for a big health system here in Oklahoma at Norman Regional for 10 years. Done a lot of healthcare technology work and health information exchange. And one of my passion projects has been advanced care planning for the last 10 years. Today I'm primarily focused more on my clinical practice. I did 15 years inpatient and outpatient and hospitalist work. So that a wide array.
Yeah. I mean, I love that you've been working on this for so long because I think it is such an important thing, but often overlooked. So, Brian, maybe you could start us. Let's start off with the doctor perspective. What is an ACP? What is advanced care planning?
Advanced care planning is really very different than an advanced directive. Advanced directives are primarily do you want us to restart your heart or to breathe for you at the time of an emergency, often appropriate at the end of life, but things that we typically start a bit too late before those interventions haven't already been applied when someone's in an acute situation. Advanced care planning is really a proactive document about your health, your wishes, your desires for your quality of life. Can include the details of some of the emotional components, such as who you want present, things that you want done should you pass. Really has a lot of nuanced details about feeding tubes. It gives the patient an opportunity to create a much more refined vision for what they want their health to be, which those data points, when presented appropriately, should someone have an emergency or a critical event, they can present those to their provider at the time. And as we all know, healthcare is more fragmented than it ever has been in the past. The days of me showing up being your primary care doctor and the guy admitting you in the hospital is really gone by these days. So with that fragmented care, these types of documents and having that empowerment to both the patient and with the family members who can present that and say this is a valid document really helps to guide the providers in terms of some of the critical early decision making, and can make a massive difference in terms of outcomes and or some of the undesirable outcomes.
Yeah. Aaron, what would you add to as far as the ACP, and let's also expand the conversation, talk about why aren't people doing ACPs today?
Yeah, absolutely. So, I think from my perspective, not only is it everything Brian said, but as I watch and I've seen people around me, I think it gives you the ability to start a conversation with family members so they understand how you want to be treated in certain medical situations. And getting one in place is really important because at any given point in time, any one of us can have a critical event occur where we might not be able to advocate for ourselves. And having that documented ensures that our wishes are followed, right? And helps facilitate those conversations. But some of the challenges there, and what we've seen is really twofold. So from the individual's perspective, not everybody is familiar with what it is, just like Brian articulated. It's a little bit of an emotional and difficult conversation with family members. So you got to get over that initial, right, hump to start it. There's some studies that kind of show that people think their doctor or someone else should automatically start it and take care of it. And on the provider side, and I know obviously Brian can speak to this with his experience, but there's a real big limitation on time, training, and tools with everything that goes on in the provider office to be able to stop and focus on this.
Well, Aaron makes a great point too. One of the most challenging things, and I'm sure we'll talk about this later, but one of the most challenging things is when you enter an acute care situation, many times you're dealing with multiple physicians who may have multiple opinions about what the prognosis is. You may have disagreements between family members. And some of that emotional distress is very high. So having a clear plan, really in terms of the distress between sons and daughters and husbands and parents, those types of things are really critical. And just in my experience, both inpatient and outpatient, those are some of the greatest barriers to making some of the quicker decisions that really truly need to be made. And it can become quite emotional and a significant point of conflict between families. And I think a lot of folks have experienced that. And that's honestly one of the reasons why I'm most passionate about doing advanced care planning. And the providers need a roadmap. It allows the providers then to get on the same page about what our outcomes and our goals really need to be.
So Brian, share a few stories about that, like when an ACP was in place versus maybe a story when it wasn't. And I don't know, did it lead to fights between family members? I've tied to some of these discussions with my family, and I've talked about this so much that I probably treated it too lightly, and I forgot that for them it was a new topic. So
Right.
it was, that was a challenge. But I'd love to hear some stories from your end, when an ACP was in place and how that helped facilitate a good outcome versus when it didn't.
One of the better examples that I have, I took care of an elderly lady. She was about 86 and she had multiple medical problems and she developed a lung mass. And 2 years prior to the event, I did an advanced directive with her, not an advanced care plan.
Mm-hmm.
And it was in my chart in my clinic, not in the hospital, right? Her family did not have that advanced directive. Fast forward, unfortunately, and as many cancer patients do, she wound up forming a blood clot and having a stroke. But her wishes were very clear to me in the primary care office about what she wanted, and she did not want to suffer, and she did not want to be intubated. And she knew her time was near, and she didn't want to be a burden to her family. She has her event, and I get a call to the emergency room. I go, and the daughter that was present knew the mom's wishes. The daughter that lived in California did not. And she wanted mom kept alive until she got there, which I understand and is a significant, moment for patients. So we admit her to the ICU, but I'm kind of managing things without intubating her. And then the daughter from California wasn't there yet, and she wanted to be intubated. And I as a physician, I was really challenged by that, right? Because I knew exactly what the patient wanted, and I had my own feelings about what I was doing and how I, didn't feel good about that. It was not her wishes, but because of that conflict within the family and just having a DNR basically on chart, but old, not updated, wasn't the nuances of advanced care plan. We proceeded with innovation, and she had had a massive cerebral event and was never verbal again. We wound up having to trach her, put her on a feeding tube, and it took her the better part of 3 weeks before she passed. And the daughter showed up, but it was a difficult and emotional event, both for the family and the conflict that resulted from that. And I carried that. I knew that I didn't follow that patient's wishes, but because things weren't well documented, I had nothing to fall back on, right? And so medical legally, I had no other choice. many times, if a patient has an advanced care plan in place, and a lot of the nursing home patients that I would ultimately admit would have those in place, and we'd have a significant event of, a significant cardiac event or neurologic event, massive stroke, and we would not advance measures, and we allowed those patients to die peacefully. The families are in sync. It's very tangible, right? And while it's emotional to lose a parent or a loved one, it's better when the family is on the same page, and it's very clear to the providers, because many times, unfortunately, and I'll be honest, most of the time in healthcare and in the hospital setting, we were performing procedures and interventions that I knew were otherwise futile. And until I could get the family on the same page, we continued to do that. And we're prolonging suffering and discomfort with really no, ability to kind of stop that train. Once those dominoes start falling, that we do our classic interventions, follow our protocols, and that's where we're going to be. And it leads to a lot of additional distress and expense long term.
Yeah. We need to be comfortable having these uncomfortable conversations. Aaron, what does it take to get more patients to do these ACPs so that, I think Brian's right. It's going to be uncomfortable if you're losing a loved one regardless, but at least having one in place, they're doing their wishes, and that probably adds some comfort to an uncomfortable situation. But Aaron, what does it take to get more patients to do these?
Yeah. So, and it's a great point as well, right? That most people actually want to get these in place when it's not this emergent or urgent situation. So, because that's already difficult enough, and it's something you can take care of ahead of time. So I think it really starts with the start where, they've got to be able to have a conversation, or at least get hopefully prompted by their provider when they have an interaction, right? That helps them understand that it might be a good time to do that. I think it's also really important when, as any patient or individual goes through that experience, they have a good experience. And maybe I'm thinking about it in such an optimistic way, but the more people have a good experience, the more people they'll tell it's not so difficult, and hopefully more will go out and have it. And then the other thing that's, I think, really important too is making sure they know that when you finish, they're going to have documentation that's within their control and portable, so they can share it with their loved ones, their providers, and make sure that it's not in a drawer somewhere, but that they can share it and everyone knows where it is and can help follow it, should the need arise.
Interesting. Brian, anything you'd add? And talk about what is the ideal workflow? You've been working on it for a decade. What's that ideal workflow for collecting an ACP? I might need it for myself. So let's hear what's the right way to approach this?
Aaron brings up a good point, right? In terms of the logistics of how you do it and when you do it and broaching that conversation. And so many times, as a patient's primary care doctor, if I try to go down that path with them, one, it's uncomfortable. And their first thought is always, does he know something that I don't know? Does he think I'm going to die? Right? That's natural human behavior. And that's really, that alone can chew up 10 minutes to then walk through why we're doing this. Most patients, at some level, once we get into our, late 40s, 50s and above, have had some type of an experience in the hospital where a loved one passed away, and it was, or went through cancer, and it was a good or a bad experience. And so in terms of workflow, typically if I introduce the topic, but in terms of today's healthcare reimbursement, like my ability to do the advanced care plan in the midst of a session really frequently winds up going down, many pathways in terms of their health and their medications or their heart or whatever it is that we're talking about. And so those can become extremely challenging. And so there's not the time, no matter how well intended that I am, I cannot get that done.
Yeah, you ruin your schedule for the entire day, probably, if you
Right,
do.
exactly. You need an hour and a half, right, between the visit and getting through that advanced care plan. Medicare doesn't reimburse at that level. The Medicare allowable code for advanced care planning is beneficial. And when done with extenders of the provider, I think is very powerful. So whether it's case managers or chaplains, or in the system that we're establishing with DrFirst in terms of where we have a trusted third-party source that specializes in advanced care planning, having someone that's not their direct provider perform those advanced care plans allows them to stay focused on that topic. It's less emotional. There's less mind reading that goes into it, you know, for lack of a better way to say it. And I think that the patients can really focus and do those. I will facilitate the advanced care plans at times, and I think that the response to patients is very good, but it's difficult for me to perform that role. So having a third party do that really facilitates it. In terms of workflow, the provider queuing that conversation up for the patient is really key in terms of their willingness to then engage. And when I reference the third party source is trusted and of high value, of course, that changes the entire equation from a 3% adoption level. You can get to 20, 25. It's still a difficult conversation that patients don't always, they're not always ready to engage in. So the second element of that is completion of the advanced care plan, and getting a copy back to me, of course, is great. However, I'm not there in the hospital with them anymore when an event should occur. The patient having the document, having it portable, digital on their phones, having their loved ones have it is really the key. And so the system that we've created is exactly that. The inhibitor around healthcare today is the cost of doing that service inside my clinic and or the health system is really also somewhat prohibitive. The time required even for a third party to do an ACP is about 30 to 45 minutes, and it may require subsequent visits. And at that level of reimbursement, it's quite challenging. The other component of that is just specifically to the point that I said. So we may invite 4,000 patients. At the end of the day, if we get 500 to complete an advanced care plan, then that is terrific, right? However, how many of those patients wind up in the hospital with the document, right, in the next, year, 18 months, 2 years, where that document's really viable? So the other key point of that is updating them. So doing annual revisitation to the advanced care planning with the third party and our systems. We've built those types of workflow, which I think are critical. The other key component is, in terms of the health system and how you look at this, those 30-day readmissions are a significant issue in terms of reimbursement. Having those advanced care plans in place is profoundly important. But if I start with 4,000, I get 500 to do it. It may be just 20 patients that we intervene on within that year, right? That would have a readmission. An ICU stay, maybe it's 10 or fewer, right? Those dollars can be significant in terms of return to the health system, and then the granular impact on quality measures and the reimbursement around that is otherwise a bit fuzzier, right? So all these inhibitors, I think, have kept healthcare from performing this. But the challenge of that is doing enough of them to where you can see that impact. And if you avoid even 10 readmissions or 20 and 10 ICU stays, that's a profound return, right?
Yep, absolutely.
And that's a direct impact on those quality measures. And so that's, I think, where we've set up this best practice, because I've worked on this for 10 years, trying to sell this directly to providers in the health systems where they do the work themselves, or you send the invite to the patient, but there's no lead in and follow up, no direct facilitation. We've had, unfortunately, 2-3% success rate. The best success we've had in the space is actually with the payers. And, United Healthcare has an initiative and they're doing some of this themselves. And that's been powerful, but they're also not the patient's direct care provider, and it allows them to get them done.
Interesting. Aaron, I mean, obviously at DrFirst with Backline, you're offering a solution around this. Talk to us more about how, some of the challenges you faced and how you overcame them with your solution.
Yeah. So, I think when we're looking at it, and like Brian just said, some of the past attempts have not been successful. So we really decided to take a look and peel back what those challenges are. And some of that is the provider times, it's the emotional component, it's the lead in, it's the follow-up. And so we structured it in such a way that it makes it very easy for any provider to just refer a patient into the platform. It's very easy for the patient to schedule an appointment at a time that's convenient for them, so they don't need to be rushed. And because they can do it over their computer or their phone in a telehealth setting, they can be somewhere that's comfortable and relaxing, which is also important just given the nature of the conversation, or if they want to have documentation with them, they can do that. Ensuring that when they meet with someone and they come back in, they can meet with that same person, right? I mean, I think we can all
Retell the
understand.
story.
Right. You want to retell and they don't know what you talked about. It'd be a huge challenge to it. And then, like I said, and making sure that they have access and they get all the documentation that's required to share it, and just ensuring that while it might not always be a pleasant topic, it can be a pleasant experience from end to end in walking through it, and ensuring that who they're talking to is someone who focuses on this. And this is what they do, right? They don't do it once every 15 days, maybe, right? This is what they do day in and day out. So they understand what you're going through, the questions that need to be asked, the emotions involved. And so they're very skilled at being able to help people, get through that and document what their wishes are.
And so is that a DrFirst clinician, or are you working with the customers to do that? And then also, what does the patient get coming out of a visit like this? Is it the portable record that Brian talked about, or talk about that as well?
Yeah. So the DrFirst component is really it's more the technology platform. It allows for the scheduling, the telehealth, and all the other components, where there's referring providers on one end, and you have an option on the back end where we have selected groups that focus on this to be able to attach to the platform. And so you can put a patient in and they can speak to someone who's specializes in it. But if you are in a larger system, and let's just say you had some capacity with the appropriate individuals, you can use the same system to route from the point of encounter to where you have capacity, right? So they can schedule their time available, make them available, but you can still utilize the platform in that manner. So it's meant to be flexible, right? Think of it a little bit more like in-source, outsource, or hybrid model. It will support all three along the way. And then what you're left with is you're left with your documents. So right now, I can say I know that all the providers on the system currently use my directives. So when a patient comes in, not only is their wishes documented, but an account is automatically created for them. So no charge. Those documents are in their account, so they can go off when it's done, whether it be 1 or 2 sessions, whatever they require, and they can get it witnessed and signed. They can share it with whomever and wherever they see fit, and that will stay with them. And then if they wanted to come back in a year later, like Brian talked about, and revisiting it, they can go in, they can update it. They'll have the same repository, and they can take it wherever they want to go.
Awesome.
Yeah.
Well, Brian, I think we need one more story before we wrap up. What is it like when someone comes in with this My Directives, ACP already done? Talk about the impact for a patient, maybe in the emergency setting or the clinic setting. I'm not sure how that differs. It'd be interesting to hear as well.
The patient, as they come in and have those documents completed, or at least some point in the process, and they may want to ask me questions, right?
It makes sense.
In the primary care setting, which is which I think is terrific, but the conversation's already been facilitated to a point to where we can get to the key elements.
Right.
All of this is billable to Medicare, even our third-party service providers, and that's what pays for the project, right? It pays for the facilitators and the platform. So the cost model becomes easier. Patient shows up, I'm able to facilitate that conversation to maybe help them get to done or just review it with them, right? They absolutely prefer to review that with their clinician. Like, am I making a good decision here? What's your thought?
Sure. They want some
So
confirmation.
that conversation can be boiled down to 10, 15 minutes or even briefer, right? Depending on the patient and the environment. It does create an opportunity even for where I can bill again for ACP consultation. So I can work my time and reimbursement levels so that I have the ability to do that financially, right? But the huge satisfier to the patients. Not a single one has ever come back and said they had a displeasurable experience. And it's been very meaningful to them and their family. And so the ones that have done it successfully and completed, the next thing you know, their husband, their sister, they're referring someone else to get that done. And it is a trust process. That continuity is really key. And as a provider, you know, in terms of the workflow and the process and patient satisfaction, you fear that, you know, I'm going to lose my stickiness with the patient, right? But I send patients to home health and physical therapists, and I don't lose my stickiness with the patient. And this is really no different. And then they have that opportunity to come back. And some of the feedback from providers that were reluctant to do advanced care planning outsourced has really, they've been some of the strongest advocates. We care, like we want this done. In the acute setting, it just changes the entire experience completely. The family's on the same page. It's very clear what mom wants or the daughter or the husband. And that process is much smoother. And the emotional conflict that can arise and frequently does in those settings, the families, you know, I've witnessed many families torn apart by these moments, right? And may never speak again. I mean, I've seen it a lot. I've seen physical altercations, right, in the ICU trying to decide what to do with grandma. And it completely changes the process, the outcomes, the comfort level of the patient. And it allows people at a critical time to focus on what's important, the person that's in that bed, right?
Yep.
The valuable minutes or moments that you have with that person while they're still conscious, able to have those conversations, it allows that to be meaningful. You know, it allows that to be powerful. And that's the things that I witnessed that by far mean the most, right? You know, no matter what you've done in your life, how big a business you built or what kind of work you did, you know what everybody talks about at the end of life with their families in those rooms? The last Christmas, that funny sweater, right? The ski trip or the things that they did. And it's those family, personal, private, vulnerable moments that really make a difference. And when you're able to focus on those things, the grief process for those survivors of the event, right? The remaining family members is a different experience. The regret, the fear, did I make the right choice? Did mom suffer needlessly, right? Those things are so much, the long-term ramifications for the family are really where this is at.
Yeah. You don't want grandma's last memory to be a fight between the kids. That's a really, really good point. Aaron, what else would you add? You know, and you know, I'd love to hear more about the reimbursement that Brian mentioned. I think people are, you know, they want to do this, but you know, there's also the realities that time is limited. So, yeah, what else would you add?
Yeah, I mean, I think, you know, Brian obviously has the experience, was able to really capture some of what happens and can happen in real life. And I think we've all witnessed that to a certain extent. I've seen it even in my neighborhood with families as members age, and the fighting and the frustration. It just makes it so much more difficult. Whereas, you know, everybody's on the same page. It's still difficult, but it's not difficult with each other. You can be there for each other. But the reimbursement aspect, so Brian hit on it, where the reimbursement is in the industry, and it makes it a little difficult sometimes with all the other demands in the provider office. That's why, as we looked at this, this was really meant to be something that's available, that you can refer into. There's no impact on the provider that puts a patient onto this platform. Instead, that's all handled on the back end. Service providers are able to pay for their time by just submitting their claims, and they take care of the technology component on our side. So it really leaves where you only have upside by putting a patient into the platform. The patient gets to have a very meaningful experience with individuals who are very trained in doing this, right? Someone else is taking care of all the billing and submission, because everybody loves dealing with all that paperwork, right? And, and for the patient, let's just say if it was a Medicare fee-for-service patient, then they just have their typical 20% co-insurance, which it depends a little bit on your location, but say for a 30-minute session, it's under $20, which is equal to or less than it would cost to walk into your PCP's office and have a visit.
Yeah.
So
it's almost the cost of a Starbucks drink. So that's
nowadays. And I mean, yeah, and hopefully it's way more value and a little more peace of mind.
Yeah, absolutely. Any final thoughts, Brian, on kind of this whole landscape, and what difference does it make going from 2% to 25%? I think that's an interesting way to look at it, right? And a realistic look at, hey, yeah, there's some people that aren't ready to have this conversation. They don't want to have it. They're probably not going to, but that's a big jump from 2 to 25.
As a primary care doctor, it's easy for me to put my head around this, just because I know that I have to make so many interventions on blood pressure or blood sugars, right, to ultimately reduce long-term relative risk of a heart attack or stroke. But it's a law of averages types of thing, right? And so you have to do such a quantity of these to see that near and medium term return financially, right? In terms of paying for this service and making it work. So this reimbursement's been around for years for Medicare now at this point in time, very poorly adopted or very poorly performed in terms of completion rate of the actual advanced care plans. Plus, most of the time, then it winds up in one chart in one place. And most of these events may happen while you're on a trip in Missouri, right? Or you're somewhere else, or you're not able to get back to where that document exists. And so that portability, the awareness of the family, those are really the key elements. And by putting the pieces together, it's been a 10-year journey for me, right? Like, we've tried it the hard way. We've tried it the traditional way, and it's not worked. But looking at this in terms of how we deploy many other things in healthcare through trusted third parties, I think that it's an economy of scale. And you've got to have scale to then ultimately have clinical outcomes and success with this. And dollars and cents, right? It's the right thing to do for patients. I feel passionately about that. It's the right thing to do for families. And honestly, I'll be, from a selfish perspective, it's the right thing to do for providers, right? Sitting in the ICU, taking care of a patient, and there's that conflict. I'm stuck, right? And the patient may be telling me one thing and the family's telling me another. And that is the most difficult position to be in. And at that point in time, I'm not going to say much, right? Because my risk goes up. And if I start, talking about prognosis, I don't have that crystal ball. Mm-hmm. Handing that decision and the empowerment back to the patients and the family with a clear plan walking in. If I'm going to go on a 12-day road trip to 5 different cities, do I go with a plan? Life's so different.
Yeah.
Yeah. So, and I'd say Brian hit on a really key point too, right? Like whether he's managing blood pressure or anything else, we all know, right? We should eat a good diet, we should exercise, and you have to do that continually to, either improve or maintain where you are in health. But when you talk about increasing the percentage or the uptake rate of having an advanced care plan in place, how often do you get immediate gratification? Meaning, when you have it in place, it's done. You have it in place. You don't have to do it 3 days, 4 days a week, week over week. It's there, it's done, and the benefit is immediate for everybody.
Nice. What a good point. And I think it is such an important topic. I loved how you framed it, Brian, that the patient benefits, the provider benefits, and the organization benefits long term from some, having those, we have enough burnout clinicians that, it's interesting. There's a burnout angle to this as well. Them having to deal with patients and families that aren't on the same page. So, Aaron, Brian, this was awesome. This is really interesting and important conversations. I appreciate you taking time to talk with us about advanced care planning and pushing that forward so we have more of that available for patients and for the doctors who care for them. So appreciate your time, and thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks, guys.
Thank you, John.
Thank you.